Hi, my name is Cassondra Henderson. I am a maternal fetal medicine provider, diabetologist, and certified diabetes care and education specialist. I'd like to thank you for joining me for this WPSI How I Practice series. This discussion is diabetes during and after pregnancy. First, a disclaimer. The contents of this presentation are solely those of the author and should not be construed as conclusions or suggestions or recommendations supported by HRSA, the Department of Human Services, or the U.S. government. WPSI recommends all pregnant individuals get screened for gestational diabetes. Gestational diabetes affects approximately 2 to 10% of all pregnancies in the U.S. The screening gives an opportunity to identify a group of individuals who are at risk for developing type 2 diabetes. 15 to 60% of individuals who have gestational diabetes will develop type 2 diabetes within 5 to 15 years. We know that there are interventions that may be able to decrease that risk or actually prevent type 2 diabetes, and discussing this during pregnancy and having an opportunity to engage a group at risk, it presents a wonderful public health opportunity. The risk factors for gestational diabetes are the same risk factors as those are for type 2 diabetes. These include being overweight, obese, having a previous pregnancy complicated by gestational diabetes, having a first or second degree family relative with type 2 diabetes, delivering the infant at more than 35 years of age, having a previous infant that weighed more than 4,000 grams, having a history of polyovarian syndrome, or being a member of a racial or ethnic group that has an increased risk for developing type 2 diabetes. These include Native Americans, Black or Hispanic Americans as well. WPSI recommends screening for all pregnant individuals for diabetes. Ideally, this should occur after 24 weeks, with 24 to 28 weeks being the preferred time frame. The goal is to decrease the adverse outcomes associated with gestational diabetes. The perinatal outcomes that affect individuals with hyperglycemia include those that result in elevated maternal mortality, as well as fetal and neonatal complications. Lowering the risk of these outcomes involves lowering the incidence of hyperglycemia. The complications for the fetus initially develops with increased urination and leading to polyhydramnios. We know that most of the amniotic fluid is fetal urine, and the complications of elevated maternal hyperglycemia, particularly over 126 milligrams per deciliter, increases the risk the fetus is exposed to hyperglycemia. And the response is initially to urinate a lot and to get rid of the fluid, leading to polyhydramnios. But ultimately, the fetus, in order to lower the glucose, results in producing elevated insulin. The fetal hyperinsulinemia results in some of the other complications, so large size, increased abdominal girth. All of these we found can be decreased by decreasing the prevalence and incidence of maternal hyperglycemia, which is the primary management of gestational diabetes. WPSI also recommends that if individuals have risk factors for gestational diabetes or type 2 diabetes, and they're noted early in pregnancy at the first prenatal visit, that those individuals actually get screened early also. So they would have a first visit screen for gestational diabetes, but that also means they do need to have the 24 to 28 week screen too. So individuals presenting to pregnancy with increased risk for gestational diabetes will be recommended to have 2 screens initially. One, to rule out that they don't have pre-gestational diabetes, that is type 2 diabetes that had not been diagnosed, and if they need to be managed earlier in pregnancy, which creates another set of risk for pre-gestational diabetes versus the gestational diabetes. During pregnancy, there are 2 recommended screens available to diagnose gestational diabetes. The first is a 2-step where the screen of 50-gram load, and depending on the prevalence of the area, practitioners may use 140 milligrams per deciliter as a cutoff for when a diagnostic test, that is a 100-gram glucose challenge test would need to be done, or if the prevalence of gestational diabetes is lower, increase, practitioners may elect to use 130 milligrams per deciliter as a cutoff because the prevalence is so high they don't want to miss any individuals who do not have individuals who have gestational diabetes. The alternative is a 2-hour 75-gram load, which is a one-step process. There is no screening. It is a screening and diagnostic test at one time. And the issue with that is that it is more sensitive, and some of the concern is that the 2-hour test actually identifies individuals who don't have gestational diabetes, so we're overdiagnosing people, perhaps. The risk factors for gestational diabetes on the right, as we discussed in the previous slide, these are the risk factors if present at the initial presentation for prenatal care. WPSI would recommend that these individuals have screening at the very beginning of pregnancy, and then if that is a negative screen and they don't have gestational diabetes, they still should have this screen between 24 and 28 weeks to make sure that they don't have gestational diabetes. The screening after gestational diabetes, WPSI recommends all individuals get screened because they are at increased risk for type 2 diabetes. The screen should occur in that week, the year after the delivery. The earliest can be done at 4 to 6 weeks, and that might work well with a normal routine postpartum visit. Individuals who have a negative screen during that first postpartum testing should be rescreened every 3 years for the minimum of 10 years. WPSI also recommends if they had a positive screen, but then ultimately a negative diagnostic test during the postpartum period, that they should still have another test 6 months afterwards. The idea is that this is a group of individuals that are at risk not only for type 2 diabetes, but also they probably have underlying glucose intolerance. So it is a continuum. And if they were negative early in the postpartum period, particularly if the weight that they gained during pregnancy was not lost, they may still ultimately be found to have type 2 diabetes during that year postpartum. Repeat testing should be done for tests that were not that specific or sensitive, such as the A1C. So even if the A1C suggested that the individual did not have type 2 diabetes after delivery, that test should be done again 6 months postpartum, regardless of whether the test was positive or negative. How I practice during in managing gestational diabetes is very similar to that recommended by WPSI. I offer the screening that's available, so A1C or a fasting glucose, or the 50-gram load or the 75-gram load. These are all options. They have risks and benefits, and I would discuss that in the shared decision-making. Really, a lot of it depends on, I found, family history. Individuals who have a strong family history are much more interested in screening and making the diagnosis early, but it's options, and I do that in a shared decision-making with patients. So the tests that are available, A1C, these are the ranges. A1C of more than 6.5 suggests the individual has type 2 diabetes. Fasting of more than 126 milligrams per deciliter, again, suggests the individual has type 2 diabetes, or an elevated 2-hour glucose test, which is my preference. I don't do the 50-gram load, the two-step 50-gram, 100 milligram glucose tolerance test during the postpartum period. I generally I strongly recommend the 2-hour 75-gram load, but will offer the other testing. These tests give the opportunity for the OBGYN or primary care providers to actually discuss interventions to delay or prevent type 2 diabetes. Thank you very much for joining me for this session. Please, if you will, scan this code to access other WPSI information, Well Woman chart, and other guidelines for supporting the prevention of disease and well health care. Thank you very much.